Hi, everybody. This is a podcast where real doctors discuss fake medical emergency. That means that unless you got food poisoning when Donna brought you the finest muffins and bagels in all the land, this podcast is not medical advice. If you need medical advice or medical care, please contact your doctor.
Hi, everybody. I'm Jackson Bain.
I'm Johnny Kolosinski. You remember me from such podcasts as the West Wing Weekly, which is an actual fake podcast I did one day on April Fool's Day. This is Hi, Everybody, a Bad Medicine podcast. Every week we talk about what medicine... No, we don't. We talk about what Hollywood gets right and wrong about medicine.
Why must you do this every other week?
I know. It's become a routine. You can find this podcast, which talks about Hollywood and medicine, at Hi Everybody MD on Instagram, Twitter, and Facebook, or at www.hieverybodymd.com.
You can also call us at 530-DOCTORB. That is 530-DOCTORB. The B stands for Bradley Whitford, I guess.
Okay.
Because we're talking about the West Wing, since that was what you set us up with.
We are talking about the West Wing Season 2 premiere and second episode, In the Shadow of Two Gunmen, Part 1 and 2.
Mm-hmm.
This is, to me, I flat out love the West Wing. It is that and Star Trek are my two favorite television program, hands down.
First episode of West Wing I think I've watched, and I still couldn't get all the way through. It is not my favorite type of show.
Mm-hmm.
Still watched it. Very, very tension. Tension. So much tension.
This one is obviously a highly dramatic one because it's dealing with the president just got shot.
Yes, it was highly trauma. There was a lot of trauma, but you want to set it up since you are the one who knows more about the West Wing than I do.
Yeah, so the plot of the episode is essentially that in the season finale of the first season, the president gets shot and thrown into a car. We find out that he's injured a little bit into the episode. He goes into, he goes under surgery. He's fine. But they reveal that only 15 people in the world know this, but the president has multiple sclerosis.
And they kind of glossed over it during this episode a little bit. Like, they didn't really talk that much about it, which, to be fair, the MS isn't going to get him. It's the gunshot that would. But, like, let's just start from the beginning where I guess they were first in the car, right, with the Secret Service, and he's like all perseverating on, who was throwing up a lot?
His daughter.
His daughter was throwing up a bunch, and the Secret Service agent accounted to stress and shock, which fair, that does happen. But then, like, he pats him on the back of the head or something and notices blood. I mean, I don't know how the blood got up there, to be honest, unless it was like capillary action from the shirt traveling, having the blood travel up his back and eventually feeling it there. But then he started acting like he was in shock.
And they also did your favorite thing of he was bleeding from the mouth.
Yeah, why? Like, you need to get shot in the stomach or esophagus or something like that for blood to finally get to your mouth. Or you've been bleeding for a really, really long time. But if that's the case, he should look like crap. Like, big time. Like, he should look like he's dying. And I guess we'll focus on the him for a second, but like they go, oh, the bullet went all the way through. You got lucky. Which, yes and no. Sometimes a through and through is nice because at least you don't have a retained foreign body. But it might be bad because the exit wound is much more dangerous than the entrance wound. Because if you think of it like a cone, the cone of entry isn't that when you enter, the tip of the cone isn't that bad, but it explodes out and it can destroy everything that it goes through.
Just like when you see a balloon get shot in slow motion on Mythbusters or whatever, you see a big violent water bursting out following the bullet.
Exactly. So it's much more dangerous sometimes. But I do like how the nurses were being all catty in their ER, going, oh no, it's this pregnant lady who is worried that her baby isn't moving. It's just the beginning of the pregnancy. She'll be back, blah, blah, blah. And they kind of are really sassy about these return visitors, which, to be fair, I am too very sassy about our return visitors all the time. Like, what is it today? Oh, your tummy still hurts, blah, blah, blah. And it gets annoying, but then they like call it trauma.
Mm-hmm.
trauma 1, and then they start shifting patients out of the ED, which is actually kind of similar to what we would do in an ER if what we call an MCI, a mass casualty incident, happens, where there's multiple injured victims. We would actually move all the patients that aren't that sick out of the ER to make room for the sickest people.
Uh-huh.
Now, if it was like a president situation, I understand why they start kicking people out, but you can't just kick everybody out.
Mm-hmm.
You know, you kind of try to divert them to the nearest hospital if you can, which sometimes the hospital will do is we'll go on something called diversion, where we tell them, look, our hospital can't accept any new patients. You need to send them to another local facility.
Yeah, you've talked about that happening. I won't go into specifics, but you've talked about that happening at your hospital.
Yeah, and it's a scary situation where that happens. But then, so they bring him in. The doctor immediately goes, give me an ultrasound and a crash cart, which, I mean, I guess when this show came out, ultrasound wasn't as commonplace usage or commonly used as it is now. So most of the time we'll have one sitting in our trauma bay ready to go. But in this case, you know he got shot in the stomach. Really, the best part of the ultrasound is to make sure there's no other free fluid in his abdomen. You know he's going to go through a scanner. You know he's going to go to the operating room already. Why are we futzing around with this part? You know?
Right.
And then the other weird thing is, and this is going to sound weird, is if you get shot, you get stripped naked immediately.
Because they want to look for secondary injuries?
Exactly. You want to look for, because if there's one bullet hole, there's always a chance there's another bullet hole.
Okay.
So usually you don't give them the chance to sit there and demand to talk to their family or whatever like that and lie in bed. You pretty much gurney to bed, scissors come out right away, and you're naked in about.
And you do have for those who I think we've covered it before, but for those who don't know, you have some pretty extensive experience in gunshot wounds.
Oh yeah. So I used to deal with that a lot in like my training. So this is one of those situations. If I saw a patient like this got shot, I don't care if you're the president or not. I don't care if you want to talk to your parent or your family or whatever. You have to get examined and whatnot before that happens.
Like he might be able to talk to his chief of staff, but he'd be talking to his chief of staff in the buff.
Correct. But even then, we'll be like, everyone out. Like if there's too many people talking, if there's too many people talking, and I can't fully do an assessment and call out what I find on exams and whatnot, I start kicking people out. And if people are adding extra pressure, like people are like parents, I've had parents jump on the child going, don't touch my baby, he's blah, blah, blah. I tell security to come and pull him out so I can do my job. Because the chief of staff is not my patient. The president's daughter is not my patient. The president, in this case, would be my patient. All right? So get out.
A question about like just the trauma situation in general. The only code word that they had for we're sending the president to you right now is the word blue.
Yeah, that has to have been established ahead of time.
Yeah. I think it would have been something more, a little less commonplace though.
Yeah, I mean, I understand why they might not want to say we're bringing the president to your hospital, because there's police scanners and people listen to the radios and whatnot, and they try to deduce where, like especially reporters and whatnot, try to deduce where the important person is,
where the VIP is.
Yeah, and that happens a lot. Like when we had when I was in a lockdown situation, the news reporters knew what was going on sometimes before we did. Which was nuts, because we weren't listening to
on the episode with the news reporters knowing what's going on before the White House staff did.
Yeah, because they listen to the police scanners and they can hear all the chatter and whatnot. So when I was in a lockdown situation, I didn't know anything that was going on until the police told me. But then at times the news and Twitter had more information than what we had inside. So it was nuts. So them making that call like that and kind of trying to divert them to another phone line, because that could have been a base station, and what a base station is they get the call and divert people to which hospital they should go to or what services they can provide and whatnot. And I think that's what happened in that situation.
Okay. So in the scene where his daughter and the chief of staff, Leo, came in and talked to him, and his wife, Stockard Channing, came and talked to him, would that have been the OR prep room or just a trauma bay?
That would just be the trauma bay.
Okay.
Because a lot of times you're not going from ER to pre-op to op. You don't have time for that. Like you have someone who's shot and you need to take them straight to the OR so that they can do a laparotomy. And that's what the surgery that he needed was called an exploratory laparotomy. They kind of effed up a little bit because the surgeon goes, oh, there was no damage to him after the surgery. He goes, we did a laparoscopy instead of
which would mean just be something investigative, right?
So a laparoscopy means you use the scope.
Mm-hmm.
So you don't really open them up fully.
Okay.
That's the difference. So usually with a laparotomy, you're opening up the abdomen like all the way through, and then you're running the bowel, which means you're actually holding each part of the intestines, running through, making sure you're not missing any holes or bleeding or anything like that, and then you're done. A laparoscopy means you make a small incision, you use like a fiber optic camera, and you just look around and see if there's anything going on. So that's very cursory.
Mm-hmm.
And I would assume that if it's like the president of the United States, you don't want to be cursory.
Right.
Especially if he's been shot through the intestines. And, you know, usually with hollow organ injuries, it's a little tougher because if you think about like spaghetti, if you try to poke through it, it's really hard to poke through a piece of spaghetti, right?
Mm-hmm.
Or penne, if you want to think with tubes and whatnot. Whereas if it's something more solid, like the meatball inside of the pasta, that's a lot easier to poke through. That's a solid organ, right?
So your liver's a meatball and your intestines are penne.
Yeah. So if you want to think of it that way, because soft things move out of the way with any kind of pressure, and bullets kind of do the same thing. You're more likely to have like a intestinal bruise, maybe a small laceration that doesn't go all the way through. Whereas if you got shot a little higher up and it punctured his spleen because he got shot on the left side, that would shatter, rupture, and he'd be bleeding a lot more.
Okay.
So usually though, it's kind of, at least where I trained, it was common practice to do an exploratory laparotomy to run the bowel and make sure you're not missing anything. Because you don't want someone to eat and then all of a sudden they're leaking poop into their intestines. Frowned upon. Oh, can I bring up one other thing?
Absolutely.
So like Bartlett, I guess the first lady, just like starts quizzing the trauma surgeon, like, oh,
she's a doctor.
Yeah, I know, but still, asking what his oxygen saturation is. Who cares? He's not breathing out of his intestines. His oxygen saturation is not the important thing. The most important thing here would be his blood pressure and his heart rate.
Okay.
Right? Because if your blood pressure is tanking or your heart rate's starting to pick up, that means you're losing blood somewhere, or you're actually having some kind of infection that's going on too, with the heart rate going up. So who cares what his oxygen saturation is? You don't breathe out of your tummy. So not necessary.
That's one that totally went right past me.
Yeah.
Like,
and then
despite my, almost 1 year of training on this podcast.
Training on this stuff. And the other thing that I want to touch note on is when they do trauma, there's a very strict algorithm you do. So it's called a primary and secondary survey. So you do this before you cut off all their clothes, you check their airway, breathing, circulation, your ABCs. That's your first primary survey, right? Then you go from head to toe and look for all other injuries and whatnot. So where did that blood from the back of his head come from? Is his belly rigid? Does he have any signs of injury or anything like that?
Why is his mouth bleeding?
Correct. Like you would look inside their mouth, check their teeth, make sure there's no blood or anything else going on, check his ears. It's very like algorithmic, going step by step. And you got to roll the patient, you got to check his butt, you got to put a finger in the bum. Not my favorite part. Not my patient's favorite parts either, but they definitely like cussing me out whenever I have to do that part of the exam, especially grown men. But that's part of the training, part of the survey to make sure you're not missing anything.
I just had a thought. In the past 40 years, someone has stuck their finger up the president's butt at least once a year since the 60s.
I feel like that didn't happen for the last 3 years for some reason.
Yeah, I wouldn't be surprised. Well, it's the healthiest president we've ever had, so.
It's a cavernous butthole. There's probably a lot of tissue to go through just to reach the entrance, and don't want to do it. Like that was a one of the most awkward days of medical school was practicing how to do that exam on live patients.
When I
And
was
people sign up to do that.
When I was working in theater, I occasionally did the pretending to be a patient thing, but I did not do it. I did not go full contact with it.
Yeah, that day was male and female, how do I say it? Sensitive exam day. And I remember one of my classmates was like a little too warm doing one of the exams and passed out face first. Yeah.
Ooh,
Not,
that is not.
It's like, is it hot in this room? Oh God, it's a hard day. Oh, speaking of scalp blacks, because I'm gonna go back. Allison Janney's character, CJ, I think that's her name.
Yeah.
They're like, the paramedic just examines her head and goes, "Oh, you have a scalp laceration. You don't need stitches," and just sends her on the way. But she had enough blood and she acted kind of concussed a little bit. Bleeding from the scalp is actually one of the biggest sources of blood loss.
Right.
Yeah.
We've covered that before.
Yeah. So like those people can go into hemorrhagic shock pretty quickly. So, unless it's like a tiny little scratch or whatnot, usually they need staples.
Yeah, and she's actively, I mean, in the next episode, she talks about how she literally doesn't remember the situation. So she's concussed.
Yeah, and that's someone that I'd probably send to the hospital just for like observation or at least stitches or more likely staples than anything. I've had patients that have lost so much blood that from falling, or I don't know that's how she got injured or not, if she fell. I don't know. Do you remember?
Yeah. She was pushed down out of the way of the bullet, or out of the bullets were flying.
Yeah, so that's someone that would almost get a trauma activation, and then I would be looking for the source of bleed. And I remembered some person I had lost so much blood pressure was tanking, giving a lot of blood. I took out a stapler and was just jamming staples into their scalp until all the blood stopped from their scalp for a momentary, for just a moment, so that we can take him to the OR. Because he was so unstable, he couldn't even make it to the OR because we thought he was going to code just during the transport up to the operating room.
Now, anatomy question. Is the reason that we have so much blood in our scalp because there's so much blood that needs to go to the brain? Or is it because we have is it like cooling?
That's a good question that I don't fully know the answer to. Your brain vessels are not related to your scalp vessels, if I remember correctly. Because your brain vessels are kind of just your cerebral arteries. So you have your middle cerebral artery, your lower or posterior cerebral artery, and I think frontal. Don't quote me on this. But then you have your scalp arteries.
News. You're getting quoted because this is a thing that we record and other people listen to.
Fair. I don't remember all my anatomy. That was like 10 years ago. But you do have a lot of musculature in your face that needs a lot of perfusion too. So that could be also another source of why. The other thing too is the scalp is relatively thin compared to like other parts of your body, that compared to how close it is to your bone.
It's thin and it's taut.
It's thin, it's taut, and it's also right underneath sharp things. Like your bone's pretty sharp. Your frontal bone and your eye sockets are very sharp, so that's why the eyebrow lacerations happen a lot. Your chin's actually relatively sharp, so if you fell, you can actually cut that pretty bad. Your nose actually has a part on there that's kind of sharp. You can cut there too. So there's actually parts where you can pinch really well and cause a lot of bleeding. But if I was that paramedic, I wouldn't be so cavalier. I'd be like, you need to go to the ER at least to get checked out to make sure you're okay. Because you were involved in the mass casualty incident. You need to get evaluated. This is one where a lot of people died, where we would do the tagging of people on scene, and if you got the black tag, you're pretty much dead. Like, it's not that kind of thing.
Yeah.
But it's enough that I would probably send them to the ER. Yep.
And one more question about Bartlett before we move on. And I know that you didn't really have a chance to research this. The MS obviously becomes a ongoing
at the end of season 2. Yes.
So all through season 2 and season 3.
Okay.
That's where we meet Oliver Babish.
Yeah.
because their president is being censured for lying about MS.
Mhm.
The Dr. Bartlett, the
Mhm.
first lady, says to the anesthesiologist, the president has relapsing remitting multiple sclerosis.
Uh-huh.
You need to know this before you put him under.
Sure.
And then she says, "Tell the press. Don't tell the press. Do what you want."
Yeah.
Isn't he pretty much under a obligation not to tell the press?
Unless the press asks to, well, it's up to the patient.
Mm-hmm.
If the patient does not want this disclosed, it's up to the patient.
Right.
So he can't say that.
Right.
It doesn't affect. It does affect his job sedating someone or putting someone
Mm-hmm.
under anesthesia, because that's actually one of the questions: is do you have a chronic medical condition?
Mm-hmm.
Because that can affect your recovery. It can affect your metabolism of the drugs. It can affect how the drugs affect your body.
It could mean that he's on another medication
Correct.
that would
So all
interact.
these, yeah, and odds are he's probably on some steroids if he has MS. So that can affect a lot of things. But the press can't ask something like that.
Yeah.
Or the press can
Like
ask
Brad,
something
they
like
can ask
that.
whatever they want, but
The
he'd be,
doctor cannot disclose it
yeah.
unless there's direct consent from the patient to reveal it.
And a direct consent from the patient isn't his wife saying, "Do what you want."
Yeah. Though, and the wife is not, the wife might have power of attorney right now,
Mm-hmm.
but does not have power over HIPAA.
Right.
Yeah. She is not the end all be all on this one.
Was HIPAA around? Like, is it that old of a thing where it was around in 2000? I want to say this episode was 2000. It might have been 2000. No, it wasn't
Uh,
2000.
I'm not sure. Let me check the Google machine. 1996. So yes,
Okay.
it was the Health Insurance Portability and Accountability Act.
Okay. I thought it was newer than that for some reason.
96.
And it was 2000.
Yeah,
Yes.
this was before 9/11 because they
Yep.
made a comment about Bin Laden.
They name dropped Bin Laden.
Yes, before 9/11.
Yep.
Yep.
I'm just going to have a total tangent. So Anna
Okay.
Devere Smith is the woman who plays the National Security Advisor, and she's also a playwright that did a lot of. Basically, she's a playwright and performer that did a lot of interviews and then performing those interviews, including a piece called Fires in the Mirror, which is about the LA riots in '96, I
No,
believe.
no. LA
Uh,
riots were not 96. 92.
92.
Yeah.
You were there. I was not.
Yeah.
Um, I worked in for one of the arts programs at Stanford for a while, and she teaches there. She got on an elevator with me, and that was the only time I can think of that I've ever been like completely starstruck, flabbergasted, and couldn't say it, and like
That's like
wanted to
me.
gush.
That was like me with the cast of The Good Place.
Yeah,
Where I almost pooped myself.
right. Where it's you, you're a playwright with a recurring role on The West Wing, and I'm freaking out like you're Patrick Stewart in my head.
Yeah, fair.
Total tangent.
A little bit,
Yeah.
but that's fair.
The MS storyline is an ongoing thing over the next 2 seasons, specifically when he's censured and then during the re-election.
Okay.
And so I know this isn't your jam, but it's one that I would love to come back to at times.
If only I knew more people who knew more about MS.
Yeah, well, we'll find them. The other big thing that happens in this episode is Josh Lyman, who is on his communication staff. He's basically Rahm Emanuel in the 90s. He's shot severely.
Yeah, so he got shot in the left abdomen. And
Yeah.
he was found on the steps, and then he passes out very dramatically. And if I remembered what the EMT's report was, and I wrote it down, gunshot wound victim, no exit wound seen on 15 liters at 92%, with decreased lung sounds on the left side, shot through the fifth intercostal space.
Fifth intercostal space, is that between the fifth and sixth ribs? Or
yes.
Okay.
I believe so. Wait, hold on. Yes, because you can't really be shot in the first intercostal space if it's between the 0 and the first rib.
Okay. So you have a 0th rib.
Yes, but think about where he got shot. He was holding pretty low down in his abdomen, right?
Yeah.
The fifth intercostal space is pretty much right below your nipple.
Oh, just below your nipple. Okay.
T4s or T4.
Oh, yeah.
So about slightly below the nipple. That is not where he got shot at all. So noticing that was a little interesting.
And not only was he holding there, but that's also where it was bleeding.
Yes.
It's not like, that's where the bullet ended up, and so that's where I'm feeling the most owie.
Yeah. Though you can have pneumonias and thoracic injuries and have abdominal pain as your presentation. So we'll have people with pneumonia with severe abdominal pain, and that's because the phrenic nerve is irritated, and that causes pain in your abdomen.
Okay.
So that's that thing. The other weird thing that they asked for was his oxygen saturation, which initially was 92%, and the one on 88. The big concern for me is if I saw someone shot in the chest, yes, oxygen saturation is important. The blood pressure is just as important.
Right. And that's not something that they called out for anybody.
No. And the reason why is you can have something called tension pneumothorax. So they were telling him he had a collapsed lung because the bullet went through his chest and his lung went down, right? Tension pneumothorax means you're having so much air entering your chest cavity on that half that it's pushing everything over to the other side.
Okay.
And when it does that, you have difficulty returning blood back to the heart, and you can actually go into cardiac arrest.
Okay.
So that's the scary part about his injury. Usually the first thing you would do is, and this is the reason why you want to know what their blood pressure is and how they're looking, is because if he did have a tension pneumothorax, we'd do something called a needle thoracotomy.
Okay.
So we put a needle between the first and second, in the second intercostal space, mid-clavicular line. You take like the biggest needle you can find, and you just pop it in there. And if you did it right, you hear this whoosh of air. And that's pretty fun. Only done it once.
I think, did we talk about that on the shooter episode?
Probably, yeah. But that's really fun because you put it in and just hear, and you're like, I did it. I fixed it.
Like a balloon, and then something bad happens.
Yeah. And I'm like, oh, I saved his life. But they were calling for a chest tube, and they actually brought out all this stuff. So they brought out like the suction canister, which is that little rectangular thing. And then they wanted to insert a chest tube into him. And that's a really bloody scene, and that hurts like hell.
Okay.
So I'm surprised they didn't like have an IV or at least mention like give him some medicine before we put this tube in, because it's gonna suck. Because what you do is you make a cut on the side of your chest, or you insert lidocaine, you cut the side of the chest, and then you're jamming your finger with the tube and a metal thing through there, and then inserting the tube in.
For some reason, I didn't think about the fact that you would obviously be wearing gloves in that situation.
Well,
and so I was like, wow, that sounds like really risky for infection because you're just sticking your bare finger in there. No, doctors wear gloves and I'm an idiot.
Double gloves for this one. All the way through, just in case if his ribs were shattered, you don't want to cut yourself and then get whatever they're getting. And then someone just calls out in the background going, I need cricoid pressure to tube him now. Can you guess what's wrong with that phrase? I know you're not a doctor, but
no, I can't. I can't deduce what cricoid is.
So cricoid is cartilage in your neck.
Okay, so you would need that if he was going to be
intubated.
So
they were yelling out, give me cricoid pressure. I'm going to tube him now while putting in the chest tube.
Right, and so that's what you would you actually need if they were actually doing like a breathing tube?
Yeah, okay. Potentially. If you look in and you can't see what's going on, then you would ask for cricoid pressure, because what they do is they push on the neck slightly, so that you can see the vocal cords and you can pass the tube straight through it.
Okay.
So that's the reason why you call for cricoid pressure, just so that you can visualize the vocal cords so you can put the tube through them.
It was the right language except for the fact that it was the wrong intubation process.
Correct. Right terms, wrong tube.
Huh.
So when I heard him, like, I actually had to rewind. I'm like, did they call for cricoid pressure on a chest tube? That doesn't sound right. So that part caught me off guard real quick. And then you find out he got shot and it hurt his pulmonary artery. It's pretty hard to hurt.
Because
it's like near your heart.
Uh-huh.
I mean, again, he got shot on the left side, so potentially it could happen. And then I think Bartlett was going, oh, are you going to use a Gore-Tex mesh and blah, blah, blah to close it up?
Yeah, okay. that was my Gore-Tex graft.
Yes, so you do use Gore-Tex for patching up stuff, mainly in heart surgeries and whatnot. So I guess potentially you can do that. But in this situation, the trauma surgeon would not be fixing the pulmonary artery. A vascular surgeon would, not the trauma surgeon.
Mm-hmm.
So kind of grilling this surgeon about everything is a little much. What kind of doctor is Bartlett?
I think she's, I don't know that it's specified. So
we have to take a break to find out what kind of doctor Abbie Bartlet was.
And she is an MD with a specialty in internal medicine and thoracic surgery.
How? Why? What?
So why is that an issue?
Unless you did 2 residencies. Oh, sorry. Unless you did 2 residencies and a fellowship. That's a lot.
Okay.
She probably would have just been a first-year doctor at this point. Because, okay, internal medicine, that's 3 years.
Right. Surgery, internal medicine is generally your general physician, like that you go to, is either going to be a family doctor or an internal medicine specialist, right?
As an adult, yes. Correct. Yeah. And then general surgery is 5 years. And then I believe thoracic surgery is like another 1 to 2 years. So that's a lot.
So she would have had 10 years of medical school, and then established herself as a career and eventually becoming adjunct professor of thoracic surgery at Harvard.
I mean, what kind of professor are we talking about here? Is she an assistant professor, associate professor?
No, she's adjunct, so she's just kind of there.
What does that mean, though?
That part-time.
That still, you can't be an adjunct professor at Harvard.
Yeah, you can.
You need to actually have a professorship before that, though.
True.
Right? You can't just be a part-time professor if you're not a professor first.
Well, she's a doctor either way.
Yeah, but I'm a doctor and I'm not under a professor name at places.
Well, wouldn't you be under a professor name as soon as you started teaching there? Because you are with an MFA.
Incorrect. There's different medical tracks at universities too. You can be an associate physician. Mm-hmm. You can be like an assistant professor. You can be an associate professor. There's many pathways, but earning full professorship. So
you can be teaching at a medical school but be teaching as a physician and not as a professor.
Correct.
That's
be a
really
clinical
interesting.
Instructor. Yeah, you're a clinical instructor.
Okay, that makes sense.
So those are very different things. So you're telling me Abbie Bartlet did all this training and now is a world-renowned physician in her very short career.
Yeah, because she's probably 50s in.
That's really tough. Unless you had some groundbreaking research or whatnot, it's very hard to be considered world-renowned. I think the only reason why she's world-renowned is because she's married to the president.
And before that was married to the governor of New Hampshire.
God, I can't.
that also means, and also at some point in time, she stopped being any of that so that she could focus on being first lady, because that becomes an issue at some point in time.
Oh, Jesus Christ!
Like specifically, when did I stop being Dr. Bartlett and start being Mrs. Bartlett? When did this become the
defining thing of myself?
The defining thing about me is the fact that I'm married to someone instead of I'm these 11 things. So she's super powered as far as credentials, is what you're saying.
Yes, very, very much so. She used a cheat code to get that high. But yes.
I forget exactly why we got on the what is she tangent.
Because she was grilling that
Oh
that
yeah.
poor surgeon about everything.
I just assumed until they name dropped him as the surgeon, I assumed that he was the chief of medicine that was there hand holding and being the liaison. But no, he was actively the guy in the room.
Yeah. I mean, I'm thinking in my situations where I've been like the doctor expert in my family.
Mm-hmm.
I don't grill doctors until they kind of give me that attitude first.
Uh-huh.
You know, like I think the only situation where I did that was when my grandmother, who was sick, was in the ICU and I was looking at her medications that were hanging from her IV pump. And the doctor just comes in and goes, "Don't touch that. Don't look at it." And I said, "Why?" "I'm trying to figure out what medications my grandmother is on." And the first thing he goes is, "Are you some kind of medical student?" And
The
I look
answer
at him.
is I was
I said,
once.
"I'm an emergency medicine attending, and I want to know why you're using these certain medications." And then he kind of was a little quiet for a while, and didn't. Oh, he's like, "Oh, so you're like an intern?" I'm like, "I'm an attending." Totally different thing.
Yeah.
So he got super mad about it too. Also, I learned that they kind of fucked up my grandmother's care. I don't care if I just swore. It was worth it. Because like they rolled her and they broke her arm and all this stuff. They
Ooh.
rolled her. So I was super mad about that
Yeah.
too. So all that together, you know, I had valid reasons why I could be upset at this attending who got mad at me for no good reason. But that's the only time I've ever played the doctor card right away. Like I wouldn't walk in and tell a doctor how to do their job.
Right.
That's not an appropriate thing. Unless I really feel like they did something wrong. Like
right.
stopping antibiotics when someone's on hospice. That's not what hospice is. I know Greg will agree with me on this. Hospice is to make sure you're comfortable, not that I gave up. And that was the one thing I had to keep emphasizing to this ICU doctor is that I know she's DNR, I know she's hospice, but you should still treat her as if she's a patient.
Yeah.
And that was one of the two or three times I thought she was going to pass away and didn't because they treated her and she bounced back. I mean, ultimately she did pass away eventually, but I'm like, come on, do your thing. Don't be a dick. But moving on to other medical scenes.
Going back, well, actually, let's stick with the one we were talking about was we found out that Lyman has the lacerated pulmonary artery, so they're giving him a Gore-Tex graft. That basically means that they're wrapping
it up. They're using Flex Seal and slapping it on. Yep.
Yeah. He's got vapor lock. And
it's okay, honey. It's just vapor lock.
And so that's a 12 to 14 hour surgery. And I know that is like, it is reasonable that those sorts of surgeries happen.
Sure.
In that situation, though, it'd be something where the trauma surgeon would get him to, you're not going to die during the surgery status, and then the vascular surgeon would come in and do the permanent work.
Yeah, so like you gotta fix the lung, right? You gotta fix the pleura, which is your lung is surrounded by kind of like a thick tissue, very thick, that helps generate the negative pressure to expand your lungs.
It's your lung bag.
Kind of your lung bag. Like, did you ever do the experiment where you took like a 2-liter bottle, you cut it in half, you put a balloon inside of it, and then you put like a balloon underneath it, and then when you pull down on the balloon, it like causes it to expand?
Yeah.
Think of that sack as the 2-liter bottle. You got to fix that so you can properly enclose the lungs into an environment again. So you got to fix that. You got to see where the lung is damaged and try to fix that somewhat. So you need a cardiothoracic surgeon for this part, no matter what. Then you got to find the artery to fix that as well, while you're maintaining perfusion to all the other organs and whatnot going on as well. So it's a very difficult, long surgery. Would it be 12 to 14 hours? Sure. Could it be shorter or longer? Probably. Do I know for sure? Nope. Because I'm not a surgeon.
Right.
I'm just a simple ER doctor who goes, "Ooh, your lung is collapsed. You need to go to the OR. Goodbye. Let me make sure you don't die here first so that you can make it up to the OR so that could be someone else's problem."
You're the doorman that sends them to surgery?
Yeah. Someone was calling for like serial crits too, because that sounds really cool. You can't really do serial crits in the emergency department. And I know
What are
you're
serial
asking
crits? Because I'm thinking Dungeons and Dragons here, and that just means you roll a bunch of 20s in a row.
20s in a row. So the crit stands for hematocrit.
Okay.
So it's checking your red blood cell load. And a serial crit means you're checking their hemoglobin and hematocrit more frequently than you would be on a normal patient. So maybe every hour or whatnot, to every 2 hours to make sure they're not continually losing blood. To order serial crits in the ER is pretty silly because you're saying, hey, order this test that repeats itself over the next day or two.
Because
you're not going to be
no one's going to be in the ER for more than X number of hours. They're going to move
in a good ER, or
right.
in a not overloaded ER, I should say. Great ERs are overloaded all the time. Case in point, my fellowship, we would house adults in the emergency department during winter for 48 to 72 hours sometimes.
Okay.
Because
of the fact they couldn't leave
the hospital, but we can't move them upstairs because there's no beds upstairs.
In this sort of situation where it's high security, would they? I guess in that situation where it was high security, the ER wouldn't be what they would convert to be a ICU. They'd get them directly into somewhere that they could secure.
Yeah, you still want them in a bed that's a little more monitored too. I mean, granted, you can keep a patient in the ER because it's technically a critical unit, right? It's a critical care unit. But you want them in an area where if they decompensate or whatnot, you have other staff there readily available.
Well,
but you also don't want to shut down the emergency department
exactly
just for one patient,
right?
Like,
even if it is the president.
Correct. We always joke around, the emergency department is the gateway to the hospital at times, like to get admitted. A majority of patients get admitted to the hospital through the emergency department. These days, it's a lot less likely for patients to get directly admitted to the hospital.
Right.
You have to stop in the ER, and the ER goes, "Oh yeah, you need a bed. Let me arrange for that."
And not just that, but if you have the president there and you want him in a secure location, the ER is literally how someone walks in. It is designed to be accessible immediately from the street.
Yes. And luckily for him, though, because he's the president, he has guards at every single opening.
But it would be a lot easier to also have him be in a room with a door that closes.
Yes. Unless he was in, trauma bays usually have a door that closes because you don't want looky-loos.
Yeah.
Looky-loos are, I would say, one of the toughest things working in the emergency department because everybody wants to look. Because when you hear the ambulance sirens and then you see people pushing a patient in on a gurney, and sometimes if there's compressions going on, people leave their rooms and try to look and peek in. And that's another reason why I start kicking people out of the room.
Right.
Like, I don't care if you want to see this. I don't care if you haven't seen this before. If you were the sick patient, you wouldn't want to be the freak show being stared at.
Yeah. I've got one more specific question about Josh. If you don't have more to say about it.
The only other thing about Josh is just his recovery after the surgery.
That's exactly what my specific question was as he's de-intubated and woken up.
Extubated.
That is a much more medical term than what I used. Generally, because my only real experience with it in family members is during COVID, so obviously some restrictions apply. Would he be able to have guests in the room during that procedure while he was
during extubation?
Was that his extubation moment, or was that after they woke? Because generally you're semi-conscious during an extubation, right?
So you need to be able to prove that you can breathe on your own before you can be extubated. So we call it riding the vent. If you're riding the vent, that means you're letting the ventilator do all your work. So that means you're not ready, right? But if you're breathing over the vent, that means your respiratory rate or your effort is above what the vent is providing. You have to prove that you are breathing over the vent for long enough and not needing the pressure support with desaturations of your oxygen to validate getting your tube removed. So sometimes, especially after a serious surgery like this, that's been going on for 12 to 14 hours, quoting the show, you're going to probably be intubated for a little while in the ICU. And then when you finally kind of wake up, realize that you don't need as many opiates to control your pain, which opiates will decrease your ventilatory status. Once you can prove all of that and you're getting up, then they pull the tube out of your mouth. So it takes a while, basically, is my whole thing. And it was kind of interesting how they woke him up, because it kind of woke him up as if he was waking up from a nap.
Yeah.
You know? Like, hey, wake up. You okay? Okay there, buddy? Gotta wake up. Usually once you pull the tube out, you're awake relatively soon. They might give you something to help you relax.
Because you basically just got pull started.
You got what?
Pull started like a lawnmower.
Kinda. Except that's not how I pull the tube out. I pull it out much more. I will say this though. I do not do extubations in the emergency department. The reason why is if I pull out the tube and something goes wrong, it becomes this whole new mess.
Mm-hmm.
I will let the ICU do it where it's much more calm and not chaotic or crazy like my department is. There's something called terminal extubations where you pull the tube and they die.
Mm-hmm.
Try not to do those in the ER as well.
You try not to do terminal processes. Let me take that note here.
Try not to kill patients in the ER. Check. The other thing that I noticed on there was usually after a collapsed lung, the chest tube's in there for a little while.
Okay.
I'm surprised they didn't show any canisters. I'm surprised they didn't have any monitors in there.
Yeah.
Especially for someone who just came out of an operating room.
How long after the operation do you think that was?
I don't know. They put the time up, didn't they? And I didn't pay attention.
Oh, they might have. You're right.
Yeah, and I would probably say it's the same day because this is TV.
Okay.
But he would still have the chest tube and canister attached to him. That thing is not a comfortable thing. Because the tube itself, for reference, look at your thickest extension cord. It's thicker than that. It's thicker than that inside of your chest. So every breath you take, that tube is rubbing against your pleura and your lungs, so it causes a lot of pain. So the fact that he wasn't waking up taking very shallow breaths and whatnot, not fully right. So yeah. And that canister, he's going to be attached to that for a while. I don't know how long it was until he went back to normal, but it takes a while.
Yeah. Oh, there's an ongoing 2 or 3 seasons. No, I guess it's either the next season or the one after. So 1 or 2 seasons later, they deal with his PTSD. He's.
Oh, I'm not even talking about the PTSD. I'm just talking about physical.
Okay.
Physical wise, he's gonna have, I don't know, at least a week or 2 of difficulty getting back to normal.
Mm-hmm.
At least. So I don't know how soon it was he goes back to the White House, which
I think he's
sounds
back
like
episode.
Which sounds like a not stressful, comforting environment to work in after you got shot.
Yeah.
So yeah, not down with that.
So you brought up the ICU versus the ER, and the ICU is a calmer place. One of the things that I had a question about was specifically the tone of the doctors and staff as Josh was brought in, because they sounded very high stress.
It's a high stress situation. Okay. Don't get me wrong. You have someone who gets shot. You're trying to control your adrenaline while trying to portray a very calm demeanor.
Okay. So that was kind of my question was, did they sound overly panicked or overly frantic to you?
I've been in good and bad codes.
Mm-hmm.
Usually during my codes, I talk a lot. I'm always constantly chattering. I want this, I want this. You got it? Okay, good. Let's make sure we have this going on. Tell me what's wrong. Give me vitals. Just yell them out at me. I need to know what's going on, blah, blah, blah. And I talk a lot, and that's my way of coping with the stress that's going on.
Mm-hmm.
It's very easy for me to be very anxious, but everyone else feeds into your energy as well.
Mm-hmm.
Parents will feed into your energy if they're in the room for some reason. Nurses, RTs, all of them will mimic what you're
RTs, respiratory therapists.
Yes, the unsung heroes of COVID, if no one knows what they do. look it up. They're very, very important. But I always try to stay as calm as possible. And I think for them, it sounded frantic, but it sounded controlled.
Okay.
To me, anyways.
Yeah.
I think about my situations where I've been in codes where the doctor is literally yelling over everyone else, going, "What are you doing? Blah blah blah. I need this." Blah. Those codes always end up horribly. And as someone who's done a lot of critical resuscitations, I've learned you take a breath, you stop. Like once you kind of feel that overwhelming anxiety and panic kind of overwhelming you, kind of just stop for a second, take a deep breath, and just restart and go, is there something I'm missing?
You do the Jack Shepherd from Lost and not necessarily count to 10, but
no, I don't have time to count to 10. Count to 2. But I'll take like a deep breath and go, okay. And I'll even ask the whole crew out in that's working with me, going, what am I missing? What are we missing? And usually asking for help like that kind of resets your brain so that you can approach it in a different path and make sure you can save this patient. Because really, this is not an ego situation, you know. And I've worked with doctors that make this all about them. Like, I'm the one who can save their life, no one else. Whereas you work with some of these nurses that have been doing this for a lot longer than you've been a doctor, and they know what's going on. You ask them for help because they sometimes know the answer and know what to do better than what you do. Don't just take your ego out of the way. And I feel you on this case, because it does sound like the doctors are really anxious and whatnot. And this is dramatized, right?
Yeah.
Seriously dramatized. It kind of sounds like
it still felt accurate in that it didn't seem out of place to you.
It's a forceful, fast talking.
Okay, cool.
That's what it sounds like to me, because that's kind of how I talk at times too. And like we'll have debriefs after cases, like what did we do right? What did we do wrong? Is there anything any of us could have done better? And that's an important thing to do. Otherwise, bad habits continue.
Yeah.
If you don't talk and figure out what happened that worked and what didn't work, you're never going to know what's wrong.
Right.
So yeah, but this patient was super sick. Like Bradley Whitford, who forever in my mind will be the enemy in Billy Madison.
Eric.
God, he looks like such a dick. The only time I've ever felt sympathy for him was like the last season of Brooklyn Nine-Nine. The most recent season of Brooklyn Nine-Nine was the only time I felt sympathy for him. Other than that.
Are you caught up on Handmaid's Tale?
No.
Okay.
Is he in it?
He's in the most recent season of Handmaid's Tale as well.
Is he a dick?
Yes, and I don't want to spoil. But he is a commander, so that tells you something.
Yep, he's a dick.
Yeah. And of course, Zoe, the president's daughter, is off-red.
Yes, which I know. It's just interesting seeing Elizabeth Moss there.
Yeah, and 15 years younger. 20 years younger now.
Confusing.
Yeah, so I guess that was my big question on this one is that was it so that didn't seem out of place to you, and it was one of those where I felt like it might have been over dramatized. So this is I know you're not a West Wing watcher, so I'm gonna evangelize for a moment and say that this is much more heightened than a lot of the episodes early on. Aaron Sorkin writes and produces the first 3 seasons, and then it's taken over by John Wells from ER, and that's when most of the episodes get more towards this tone.
This chaotic.
The very dramatic.
What else did Aaron Sorkin? He did the Newsroom, and
he did Newsroom. He did Sports Night. He did Studio 60. It's funny. It's good.
People always tell me how great it is, and I still haven't watched it yet.
Social Network.
Oh yeah.
But his first big one was A Few Good Men.
Oh, okay, that makes sense.
And The American President, the romance movie with
Bill Pullman, not Bill Paxton. It was Bill Pullman.
Yeah, Bill Pullman.
It's always easy to confuse those two, Pullman or Paxton.
Yeah, which one was the president at this point in time?
Oh God, I forgot. They both were presidents. Paxton was president in Independence. No, he was Independence Day 4 too. Pullman was.
Okay.
I don't remember what movie Paxton was the president in. Oh, that's going to be a trivia question tonight. I guarantee it too. Okay.
All right. Speaking of questions,
God damn
That was a great segue, wasn't it? I liked it.
So good.
The human centipede bills itself as 100% medically accurate.
Okay.
If that's the case, how medically accurate is season 2, episodes 1 and 2 of The West Wing in the Shadow of Two Gunmen by Aaron Sorkin?
Okay, I will tell you this right now. It is more accurate than the human centipede. The question is how much more, right?
Yeah.
God, that's a toughie. I initially wrote down 110, but I think it's probably like 130. Only because I'll give it extra points on, the whole activation of trauma, the discussion of his lung being collapsed and how he was decompensating pretty bad. The other thing I wrote down, very good transfer from gurney to bed, which is actually how you're supposed to transfer a trauma victim. That one person will hold the head, and the person who holds the head is the one who counts on when everyone else moves the rest of the body over. Do you understand why they do that, though?
Because the reason for that being that the person who holds the head is the one who needs to ensure stability of that specific
the spinal cord
inch.
Yeah, so it's really the spinal cord more than anything, right? So, and usually the respiratory therapist, at least at my hospital, that's what they do. So they hold the head and they move everything over. So watching them transfer the patient over, I'm like, good job. The rest of it, they discuss the medicine pretty well. I hate the blood in the mouth trope. I really do. It's so stupid. The worst medicine comes from Dr. Bartlett, to be honest. So thank God she gets. Doesn't she lose her medical license?
Yeah, she gets disbarred for treating him in states that she does not have a license.
Ah, man, getting disbarred in medicine, that's rough, man, because we don't have a state bar. Man, she lost her lawyer license for being a doctor. Oof,
yeah,
that's rough. Not a law podcast. I have someone else who can discuss the law, but not this guy.
It might not be that she's disbarred. I don't know if that's the term they use. I assume that Aaron Sorkin does better research than I do.
Losing your medical license is pretty much it.
Yeah,
but
wouldn't be that.
The problem is, did she lose her medical license in her state of practice, or did she lose her medical license in all the states of practice?
Yeah,
that's key, because I'm technically only licensed to be a doctor in California.
Mm-hmm.
However, when I lived in New Mexico, I held 2 medical state licenses, one in New Mexico and one in California. So I don't know how she lost her medical license precisely, but you know that better than I do. So yeah, I still stand by my number, 130.
Okay. She voluntarily surrendered it.
What?
Basically, in order to, as part of the let's keep this from going even further, she voluntarily said, okay, in order to keep there from being even more furor, she's going to voluntarily surrender it as part of the whole
plea
process.
Bargain.
Yeah,
I don't really
a plea bargain, because basically because he was being censured by Congress, and it was part of the these are the things that we will go through to say as our punishment.
This is dumb.
Okay.
From a medical, but again, politics itself is dumb. That's my political rant. A lot of politicians are making a lot of medical decisions and medical statements that are very stupid. And to make decisions like that is dumb. And I hate politics right now. I can't even watch TV. Thank God for stupid YouTube videos and Animal Crossing. that is what's keeping me afloat right now, to be honest. The rest of it is.
So for those who are listening, I just picked up Outer Worlds, and it's great, and I'm finally able to play it because I upgraded my computer, because hopefully we will be doing some streaming stuff soon.
Yeah. Please, Fateful Findings.
Yeah, Fateful Findings will be one of them.
No, I feel like Fateful Findings needs to be one when quarantine is lifted and we can all sit in the same room and stream it and watch it and make fun of it.
Yeah.
We're going to be way too podcast juiced.
Yep.
Yeah.
All right. With that, folks, anything else we want to say about what's going on, or
This whole episode could be made more medically accurate
Okay, that's a question I
if
didn't ask.
Bartlett doesn't talk. Honestly, that's a big part of it. And then just, I get the terminology they're tossing around, but it's not the accurate terminology.
I feel like it's closer than we generally see.
You know what? Closer than Chicago Med.
Yeah.
Because Jesus Christ, yeah, Chicago Med. Oof. That was the last episode that was released, I'm assuming, right?
That was
Yes.
the most recent one, yeah.
Oof. God, that was a toughie.
Yeah,
Real toughie.
that was a fun one.
Oof. But yeah.
All right. Well, yeah, I didn't ask that question, but other than Abbie Bartlet not being being in
and the recovery scene. I mean, that could be easily fixed by saying 5 weeks later, or like 5 days later, or something like that. Easily, like that stuff is all timing issues, and I get time compression in TV shows and building suspense and whatnot. Allison Janney's character needing staples, again, that could be easily spun into a much more dramatic scene where she starts forgetting more lines during press conferences and whatnot. That could be its own storyline in itself, but that would be how I would have written it. But I'm not Aaron Sorkin. I didn't write A Few Good Men, so get out of my house.
Yeah, I believe Aaron Sorkin has. No, I guess he doesn't have an EGOT because I don't know that he has a Grammy.
He has an Oscar, right?
For he has Oscars. Network? Yep, he has multiple Emmys. He has a Tony for A Few Good Men.
Wait, A Few Good Men was a musical
stage play.
Oh Jesus, I was thinking musical.
No, it wasn't a musical. No, he actually started.
Handle the truth, huh?
Yeah, you want the truth. You want the truth.
Nope, pass. Nope, that's not gonna work. I didn't know it was a stage play. Yeah, not at all. Not cultured. Come on.
That's Josh Molina, who you would know if you saw more Aaron Sorkin things. Did the stage play. He's the guy who looks just like what's his face from The League, smarmy guy with glasses.
Nick Kroll. He looks like Kid from Kid and Play.
Josh Molina?
Yes.
Okay.
He looks like Kid from Kid and Play, and Stephen Colbert had a baby.
Okay, I'll give you that.
That's who he looks like. Oh, it's terrible. Okay, close it.
All right. So with that, folks, we'll be back with you soon with more Hi Everybody Bad Medicine podcast, including possibly on more media very soon. All right, bye, folks.
Thanks for listening. I'm not joking.